the procedure in that route, then it is once again better, as because the catheter itself acts as a healer.
Have you come across radial artery transection cases? Artery transection after sheath removal? Do you have any experience with radial artery transection? But you try to put the radial artery,
Yes. That spasm, though it is not documented, we could not show. There may be sometimes so much spasm, entire vessel is occluded in the entire catheter is occluded in the vessel. In entire Bangladesh, I have consulted, or they have consulted from various centers, from Rangpur, from Chittagong, from Sylhet, and some catheter is not coming back. In this sometimes occurs. In that scenario, what is our practice? We keep the patient in the CCU, and we give sometimes even morphine, even sometimes anesthetic agent, and within few hours the spasm disappears and we able to withdraw the catheter. Once happened in one center, what I have heard, I have not seen, they have pulled back the catheter with high force and they have avulsed the radial artery. Though you can think that this radial artery is used for graft. So if you lost the radial artery, there is no problem for the patient, but we must have to honor the radial artery, as because it is a good conduit, it is necessary for the CKD patients, and for the conduit is very important, for which we do not want to lose radial artery, but it can happen.
In that case, we can consider vasodilator.
All types of vasodilator initially given, but where vessel will dilate, how it will dilate, and your artery is totally occluded by the catheter and spasm, and that is why local vasodilator is not given, as because your side arm of the catheter will not able to introduce any fluid by the sheath, and only the centrally acting drugs can work. That is why we give sedatives and anesthetic agents, sometimes if necessary.
I can show you 3 pictures of radial artery abscess. One of the pictures is in UroPCR image, so I cannot show you. But personally, I'll show you 3 beautiful images of radial artery abscess which I have in my mobile. Thank you.
Thank you very much, sir. At the end of the day, when there is huge enthusiasm and huge interaction, then this is a lovely picture of the sky. So may I now request Dr. Ashok Kumar Datta. I have never seen this before with his presentation. Professor Ashok Kumar Datta is from National Heart Foundation, one of the highest volume center of the country, and with a lot of challenging cases.
So actually my topic is I have never seen. In my first case, actually I have never done before. So, my first case, actually that was the case I have done first in my life, and that was long back. So I tried to show 3 cases. First is the faulty tap, second is when the young man started sinking, and third is jailbird. That is the faulty tap. This is the history of 44 years doctor having chronic staphylococcus strongly contaminated. angiogram shows that is the, I did it in 2014. So angiogram shows right coronary artery was normal at that time. There is lesion in the proximal LAD. And LCX. So this is the still picture. So our decision was to do the upfront double stent strategy by TAP because that is easy to perform. There is less metal mass, less hardware required for TAP, and comparable long-term report with other two like DK Crash and Kulu. So we started as usually wiring of the both vessels, pre-dilatation with 2.5 mm NC balloon, then stenting the left main to LAD 3.5 into 38. We pre-dilated the LCX also initially before doing the stent into the LAD. So post-dilatation of the LAD and left main stented. Left main port in the left main was done at that time, also with a smaller balloon. Now wire recross to the LCX. LCX stent was pre-dilated and stent in the LCX is positioned, and the 332 millimeter drag loading stent. Just to do the port, about one stud was hanging in the left main. Stent position was initially good, but when the stent was required, at that time patient moved, took a deep breath, resulting a huge pullback of the stent within the left main, about 3 to 4 millimeter. The view is like this. This is the still picture. If it is seen here, that stent is cut nearly to the opposite side of the LAD. So there is long hanging stent in the LAD. The patient was my roommate at one time. So I was in a very stressful condition at that time. What should be the next strategy? Whether I will just pull back the LED balloon and LCX balloon, do the panel piecing and end the procedure, or whether I will go to other technique to get a better result. Because I have one experience regarding like long carina in such a TAP procedure, that patient just after a few hours developed acute stent thrombosis, and that patient subsequently rewiring and retracting was very much difficult. Ultimately that patient was saved. So I'd like to request my teacher and audience and also the panelist and chairperson, any opinion from them? How can I correct? That is actually the technical fault. That is the long carina or long protrusion in the left main during that. Any opinion, please?
Dr. Sivan, do you have any comment for this actually? Anything can happen in any time actually.
So during that, there is long protrusion like this. So how?
So, do you prefer to crush first?
I think crushing here is not appropriate because you will never have a good apposition of what you are crushing inside the left main. So what I do here, I try to cross through the stent, open the straps as long as possible, and then watch, go with the eyeballs and see what happens.
So you like to recross to the protruding stud?
Yeah, it's like reverse Coulomb, like reverse mini Coulomb.
Yeah. So I thought like this, the picture like this, if I put a stent from the left main to the LCX like Coulomb or mini Coulomb, and then recross and final piecing balloon, that is one option. Other option to keep it like this with long carina in the left main but the experience was not good with me. So other option that someone was telling crash. So what I did, that time I talked with my technician and also I talked with my mentor, Professor Fazila Malik, and they decided what to do. The crash, because I have already stent in the LED, already I have a balloon in the LED, so I just pull back the LED balloon here and I pull back the LED balloon here and I crash the LCX stent, then I recross the LCX stent, then after progressive dilatation, final kissing balloon I did. So this is the final kissing balloon. Then port, that is actually port. Then I finish the procedure after doing the eyeball. So that was a good result. So this is actually the equivalent to the decay crash, where the stent are crashed, stent are remain inside the LED stent. In crash, typical crash, the stent, crash stent remain outside the LED stent, but here it remain inside the LED stent. So after 7 years, he became symptomatic. He called on me, class 3 angina. Echo normal TMT was not done. At first, probably looks AG, that was 6 months back. So this is the angiographic report after 7 years. So left was perfectly normal. RCA was normal at that time. So this is the reverse crash. I did it first time in my life, and further I have done 1 or 2 cases later on. So keynote, final result is more important than the technique that we used, and technique used depend on operator skill, choice, and attachment to particular technique and hardware that is available in your cath. This is another history of 35 years old chronic stable angina, mid-LED lesion, diagonal has got some lesion at the ostium. So that was not a difficult case. That is also a history from about 15 years back. So in this case, I was assisting with my senior professor Najib Ahmed. So pre-dilatation, that takes some difficulty to deliver the balloon. So after pre-dilatation, we put the stent in the LED that was 2.5 millimeter into 28, and post-dilatation at 24 ATM, because that was very much difficult to dilate after putting the stent. So at this point, patient became very much unstable. Patient was talking like this, I am sinking, and he was very much agitated, and suddenly he just tried to jump out of table, and anesthetist made the patient sedated, and this is the scenario. So there is dissection starting from the ostial ligament, extending up to the stent in the mid-LED. LCX is totally dissected from origin up to the tip of the OM tip of the LCX. Still we have wire in the LED, wire in the diagonal. But when the patient jumped, everything removed. So you see, this is the picture after patient settled down, patient sedated by anesthetist, and after engagement, there is nothing, there is no wire inside. Patient is in hypotension, blood pressure was 70/50 like this, tachycardia with high inotrope support. try to rewire. There was some buckling in the oil tip, so that is very dangerous in any cases of dissected plaque or dissection, whether it is spontaneous or catheter-induced dissection. So it was not sure whether the L6 oil is in true lumen or not. So try to rewire the LED because it was more reliable if the oil goes into the stent. So, because patient jumped out